Good morning, everyone, and thank you for joining us in this topic today, which I feel is very important one and very relevant, especially in geriatric medicine. My name is Sherif El-Salawy. I am with Flagler Plus Health, and the topic that we're going to discuss today is dementia. Different aspects of dementia, different um, issues regarding dementia. And I do encourage if anyone has any questions to post those questions, and I'll do my best to answer them to the best of my knowledge. So, dementia is basically put memory loss, and it is considered a pathological process. It's not normal aging. Many people believe and they just say it's your age, it's old timers. No, it's not old timers. It's definitely not normal to have memory loss. Having said that, old age is a risk factor for memory loss. So it is not normal, but it's something that's really prevalent, as you know, in older folks. Some exceptions apply. Some people get it at an earlier age, especially if there is family history. Now, why is this topic important? I'm going to touch up on statistics, and that's actually why it is important. 5 million Americans currently in 2020 have the disease. Besides being that number being big, is the burden on the caregivers and the system and all the comorbidities and the death and the suffering that's associated with it. It is the sixth leading cause of death in the US. It is estimated that 1 out of 3 seniors will die because of Alzheimer's disease. Alzheimer's disease is just a type of dementia, so it is not all of dementia. But I'll go back to that in a second. The death from dementia is more than both prostate and breast cancer combined. So, and those are the two most common cancers in males and females. In 2020, the cost of Alzheimer's disease is $305 billion. And that's because of nursing homes, ALFs, and other services, whether home health or private services, or time away from work by the family. By 2050, the expectation to be a $1.1 trillion for Alzheimer's dementia alone, because the population is getting older. As such, the disease will be more prevalent. And 50% of physicians, primary care physicians, believe that we are not ready to treat as many elderly when that time comes. Next, I want to talk about the risk factors and things that can make a person more susceptible. There's no doubt that genetics is one of them. So anyone with a history of Alzheimer's disease uh, has to pay particular attention to and be aware of that possibility. Other risk factors, repetitive trauma. We know boxers and soccer players, football players, those who have trauma to the head, they are definitely at risk for dementia, but not only dementia. Parkinson is another one that is usually associated with it. And since I'm mentioning Parkinson disease here, I want to say that Parkinson disease and dementia are very closely related. Alzheimer's disease, very closely related. They actually share the same gene. And many times, 50% of Parkinson's disease patients do have dementia associated with the disease. So it's very, very close. Um, Other risk factors, obviously age, already mentioned, female sex, but that is more of a confounding factor, is because just ladies live longer than men, and that's the reason it is more prevalent in women than in men. It's mostly because of survival and longevity, so it's not really genetical variation or difference of any kind. Um, the The other thing that's important to say here is that depression sometimes mimics memory loss. And people who are deeply depressed, severely depressed, they can have what we call pseudo dementia or false memory loss. And it's very important for us as primary care doctors to screen for depression and treat depression first before we jump on to conclusions or treatments of dementia, because person can be so depressed that they have memory loss, and it's treated and it's reversible. Once we treat the depression, memory loss goes away. um, so that is another important topic. uh, Diagnostics, what labs do we do? And labs that we do are really specific to memory loss. And I have to, before I forget, I have to mention that dementia is um, not a bad word. It's a clinical diagnosis. And I recall in the beginning of my career, when I just fresh out of fellowship at the University of Florida, I have told a family member that your mom has dementia, and she was very upset. Dementia is actually an approved diagnosis by DSM-5 criteria, by Medicare, by all clinical books and references. So it's not really an insult. Obviously, we try to use memory loss more so than dementia, if we don't forget that. And we're not trying to offend anyone. Um, the diagnosis of it, we do try to exclude reasons or things that can lead to memory loss. And the reasons that can lead to memory loss is B12 deficiency. It's fairly reversible if we catch it early. Hypothyroidism, and very rarely nowadays also neurosyphilis. It also can be treated by penicillin, course of antibiotic. And again, is it very common? Do I see it? Do I see a lot of it? No, I don't. Other causes that we see of memory loss, medications like antihistamines, Benadryl. Benadryl can cause memory loss because it increases uh, sleepiness. It is again reversible. There's some studies that says marijuana can cause dementia. Um, Types of memory loss, types of dementia. And the reason we often associate with dementia with Alzheimer's disease is because Alzheimer's disease is the most common type of dementia. And it represents about 85% of all dementia patients. It does not obviously exclude possibility of somebody having mixed type. The other type, the other second most common type is vascular dementia. It's the one that results from repeated mini strokes and strokes. It has a different course as opposed to Alzheimer. Alzheimer is insidious. It takes time, takes months, years. Starts slow and it goes slow, and it is a linear, a very, it's a linear fashion time-wise that takes a long time, and starts usually with recent memories. That's the first effect, because our memories are stored in a different bank. Remote memory is stored in a different area of the brain. It's later on in life it affects that. But in the beginning, people would forget what they ate for breakfast. People would forget where they put their keys. They would forget the immediate things. They would remember their college days, their high school days, their youth, their friends from their youth. So that is typical start of it. So vascular dementia has different the way it presents itself. It's a stepwise staircase. So a person memory is stable, and then they have an event, cerebrovascular event, memory goes down, another stability and no change in symptoms, another event goes down, so staircase decline. And that's, again, good history would diagnose that. And I'll go back to that actual specific diagnosis if there's any trouble. Other All other kinds of memory loss are a lot less common. Lewy body dementia is another one that I saw. I don't see many patients with it, but it's something we also keep in mind because the treatment is different. And it is mainly memory loss that's really progressively fast. There's waxing and waning of symptoms. So there are good days, bad days. Also some Parkinsonian symptoms with it. There are hallucinations, and the hallucinations usually are very vivid visual, not auditory, but visual. They do see things that are not present. And that is typical of Lewy body dementia. Lewy body, the name came from the histological, pathological description of a certain stain that they use in the brain to see certain pathology in the brain. Um, there's another dementia called normal pressure hydrocephalus, not syphilis, cephalus. And normal partial hydrocephalus is basically fluid, cerebrospinal fluid that's normally found in the brain and the spinal cord, surrounding the spinal cord, accumulates in the ventricles. We have two ventricles on both sides of the brain, on one on each side. And the fluid accumulates therefore because there's a stricture or there's a blockage, and that fluid doesn't flow freely between it and the spinal cord. And if there's a blockage, um, that fluid pressures and causes people to have memory loss, problems with walking, and also urinary incontinence. It's very hard sometimes to diagnose this type of dementia because when older people have trouble walking, it could be because of arthritis, and incontinence because of incontinence that people get with age. But it's very important to keep that in mind because this type of dementia is very reversible if caught early. If it's caught within 1 year of the suspect or before 1 year before when the diagnosis, before passage of time of 1 year since the initiation of symptoms, it could be reversed by a shunt from the brain, and that drains the cerebrospinal fluid, and people recover very nicely. So that's type of dementia, not common, but treatable. So we definitely have to keep that in mind. And that's usually diagnosed by a CT scan of the brain, which brings me to imaging and how effective is imaging. Imaging is not something that I would routinely use in dementia. My clinical sense and good exam, good history would be my leading ways of diagnosis, standard lab testing. I would do imaging if I suspect possibility of cerebrovascular dementia or NPH, normal pressure hydrocephalus. That would be very helpful. Um, we do use certain screening tests in the office. The simple one we call minicog, which is 3 questions, and we ask the person to repeat those 3 items to remember and repeat. And if they fail any of them, that is a red flag. Also, we do a clock drawing test, and again, that is very sensitive and very simple to administer, and it doesn't take much time from a primary care perspective to do it in the office. If any of those are positive, then we do more uh, in-depth evaluation. Montreal cognitive testing is one that's excellent for the other way around, for mild dementia, which we're not sure. People are very, very, still they have high functionality and they're very good at covering up memory loss. Yes, people do cover up memory loss. And the higher brain function and the higher level of education achieved by a person, they're really good at that. I have seen pilots, I have seen CEOs engineers, and they are very good at covering their memory loss. I would ask them, so what did you eat today? They would respond, I ate what I ate yesterday. So they're very evasive, and those guys, we definitely try to do Montreal testing. There's another test called mini mental state exam, and that is a patented test. So an institution to use that test, they have to be aware that it is patented. And I use it usually for regular um, patients. Most of the population, I use the mini mental state exam because it's very easy to administer. It doesn't take much time. Um, so those are the testing that we do. There are situations in which it's very puzzling and it's very hard to figure out if the person has memory loss, especially, as I said, those are high functioning individuals. In that case, we refer to psychiatry or psychology for neuropsych testing. It is a really intensive testing. It's not easy, but it's very sensitive, and so it's a couple hours of time. So, uh, but it gives us really a definitive answer. And I don't do that a lot. I usually do that in those cases in which I'm not 100% sure in what's going on. And so that's something to keep in mind. Driving and memory loss is very important, and that's why we have to really quantify how bad is memory loss, because somebody wandering is an issue, driving is an issue, and we have to be aware about the dangers of a severe memory loss patient on how they can affect others. Uh, so that is as far as types and diagnosis and how we approach diagnosis. One thing that I get commonly asked, which I will mention right now, which is genetics. So there is a genetic test available also. But the problem with the genetic testing, we still don't recommend it, is because it doesn't guarantee that the person will have memory loss in the future. And it causes lots of anxiety to the person if they find out that they do have that gene. Um, And so the effect might be a little bit of a lot more anxiety and depression that we want to happen. So I'm not one of the people that would advocate for genetic testing, because I do believe that it can cause more emotional harm. Um, the pathology of Alzheimer's disease is structural. There's a type of paraprotein that accumulates around the nerve cell, and it causes the nerve cell to die and atrophy in a particular part of the brain, which is called hippocampus gyrus. It's the brain, that's a part of the brain that's responsible for our immediate memory. And so it starts there, and then it starts spreading out to other places. Um, treatments. So treatments, unfortunately, there is lots of research going on, but as it stands, the treatments we have available are they slow down progression of memory loss. Nothing that would stop it immediately or reverse it. Obviously, as clinicians, as doctors, we would love to have something that would stop the disease in its track or reverse, which would be awesome. But that is not the case, unfortunately. The medicine we have uh, Aricept is a Aricept, Exelon. That type of medication belongs to a category of acetylcholinesterase inhibitors, and increase in particular neurotransmitter in the brain, and also in Namenda, which is NMDA, and memantine. And again, it's a second medication. The first group of medications can cause nausea, dizziness, fall, and we definitely have to start low, go slow. If we start, and the approval stage is different. Some approved mild, moderate, severe. Some approved moderate and severe. Some approved mild to moderate. And some approved, the Namenda is approved for moderate and severe. And obviously, we can use it the way we want. We can use anything for severe, anything for moderate. We combine them often, so we can get maximum benefit. And the whole idea of those medications is to slow down the progression, meaning keeping the person in their environment, keeping the person as functional as possible, as long as possible. There is something called Axona, which is medical food. The jury is still out about how effective it is. And so I don't usually prescribe it. Sometimes when it's like a last-ditch effort and it's more of a desperation. I definitely don't recommend anyone to use anything unapproved, non-approved. We hear about transfusions. We hear about people going to Mexico for alternative treatments. None of that is proven, and chances are could be even harmful. So I would refrain from using anything that's not FDA approved and doesn't have a track record. And I do understand that people become desperate at times. It's a terrible emotional burden, and caregivers often have depression, heart attacks. We know they have a lot of comorbidities just from taking care of the family member. There's the fact that mom and dad that didn't recognize them anymore. It's very painful. It's very so there's it comes with that toll on the person. And providing care in general, once it's advanced and they become incontinent, unstable behavior, anger, agitation, wandering, uh, it becomes problematic for many families. Prevention wise, unfortunately, we do recommend many things, but again, they're not 100% proven. You'll see a study that says yes, it works, and you'll see a study that says it doesn't work. And the things we recommend, which are beneficial and the common sense, would be physical activity, obviously eating healthy, decrease alcohol intake. Um, they have programs nowadays that video games that stimulate the brain, that could be helpful. Reading, because it creates a picture in the mind rather than a passive movie watching. Um, uh, Crosswords, not cuss words, but crosswords, the ones in the magazine and newspaper, that could be also helpful. Um, so those things, and again, they are not 100% proven to prevent memory loss. It's unfortunate that in spite of those efforts, people still can and will develop memory loss. So this is something uh, that can happen and will happen. Um, I think I touched up on most of the of the of the dementia in general. I just want to last thing I want to say. I really was hoping that we would have more community programs in which will keep, first of all, programs that would keep people active, um, because boredom really is not good for the brain. And the other one, once the person reaches memory loss that's severe, programs such as wandering programs. I know there's some, but they're not really that effective. And making your home proof to your family member that to prevent wandering is important. Taking the keys away once uh, are aware that they are become a problem, they may become a problem for others and their safety. It's not a bad idea. Um, we as providers have that. Also, we can do that too. We can take away the driver's license, but that doesn't mean that they're not going to drive. Or that the keys are available, the driver's license is not going to stop them from driving. Um, at this point, I want to uh, thank you very much for joining me this morning in this topic that I really think is very, very important. And I always tell people just watch The Notebook. It's a movie that's very descriptive of of all the aspects of this disease, and including the emotional one. And I'm really open for questions. And if you have any questions, please feel free to ask me now. You can also, if you have a question later and somebody's watching this beyond the live broadcast, you can also contact us, and the marketing team here at Flagler will be forwarding those questions to me, and I'm happy to answer those questions to the best that I can, of course. Thank you so much for joining me. I do not see any questions, but that doesn't mean there are not. Are there any questions? I don't see any questions. Yeah, I don't see any.